It's it's a great pleasure for me, a great honor that I meet good friends and great colleagues as my friends Naren and my friend Desi. I love you so much. I admire you so much, and I hope in the near future, after coronavirus, to see you again. Don't forget to tell my greetings also to Guri Solanki. Okay. Great colleagues as my friends Naren and my friend Desi. I love you so much. I admire you so much, and I hope in the near future, after coronavirus, to see you again.
Good.
Desi, I remember also I remember our meetings during the ESPN courses.
I remember. In fact, last time I missed you at the, I was in Bonn, but the ESPN Congress, and I was asking.
Yes, but I didn't manage to come because the cost is too much to come. But and also it is a great loss that we miss our friend from New York, Woodridge.
Yes, yeah.
A great miss from the world of pediatric neurosurgery. Also, Naren, she was very friendly with him. A great loss.
He's dead.
Probably these meetings is our future, eh?
Yeah, it is good. You can meet more people at least. Look.
Yeah, it is good, and you are more concentrated in the point, and you don't want to go around and to see the other things.
Correct.
Such beautiful girls and other things. Okay. I apologize, Naren. Perhaps I speak too much.
No, not at all. Not at all, Nicholas. I'm just going to give another 5 minutes for people to join. If that's okay, then we can.
I'm a very emotive person. You know me well. Desi, he knows me better because we were for around 4 or 5 years around in all the congresses. Okay. Perhaps it's the time to don't speak too much and to do much things.
I'm just giving 5 minutes, if that's okay, Desi and everyone, for anyone who is joining. I'm just making clear now.
Desi, did you speak with Pasquale Gallo in Edinburgh? Did you speak with him?
In fact, they just visited the unit the other day, but otherwise, no. Yeah, I met him recently, yes.
It's very friend of mine with Pasquale. I spent a lot of time in Verona, Italy. She's very friend of mine. Very nice guy, very nice person.
I met this one, Pablo Frasianto, whatever his name.
Yes. Where did you meet him?
I met him recently, before the lockdown, of course. Where did I go? I went somewhere and he was there, and I just bumped into him. I said, "What are you doing here?" He had just come for a visit also. Both of us had visited the same place. It was
Paolo also. He's a very nice person and a very good pediatric neurosurgeon.
Yeah.
He takes the heredity of Di Rocco and Caldarelli now.
Where are you now?
I spent also big time in Rome with him.
Oh, I see.
And in the courses, I do around 10 or 11 ESPN courses. I met him also there. We were in the same room in the course.
He's also a jolly chap like you.
So we'll give another 3 minutes, and then if that's okay, then we can start. So just.
Naren, also, if you have time, tell us about this University of Pediatric Neurosurgery if you want.
Yes.
It's very interesting. I really want to participate. I sent you also an email, but
Absolutely. Thank you very much, Nick. I
it's
really
very
hope.
interesting for the young neurosurgeons all around the world. Very interesting and compliments for this activity. No, you know.
Fantastic. I really hope you will all join. We'll just give 2 more minutes, then we'll start.
Daisy, you look younger than you were 10 years before.
It's the COVID infection which is having an impact on me. It makes me look younger daily.
Mhm. We're almost there. Just 1 minute. We'll start very soon. Good afternoon to everyone. Thank you very much for coming to this neurosurgery roundtable. The aim of this roundtable session is to present the results of the survey and also to discuss the results and how different people um, have their own practices and what might the reason be. The reason for the roundtable are threefold. One is that I know that many of you have contributed to this survey, and I was keen that you knew the results of the survey than waiting for another 2 years for it to be published and then pay to get the paper. The second is that it's nice to have a online forum or where we neurosurgeons, we do meet, which is getting less because of the COVID. And also this meeting is about not about right or wrong, or it's mainly about what is the current practice, what's the commonest practice, and I hope that all the attendees will join in the discussions. If you have a different practice, or if it will be good to know how your practice is different, or if you are on the minority of the a practice that's on the minority on the survey, then why you do this. So it is all about learning from each other, and so that's the purpose of it. And in terms of how to let me know that you want to contribute to the discussions, you can either, the best thing is to type it on the chat box. I'm sure by now you all know about the chat box, and then I can make your mic come on. So first of all, it's my pleasure and privilege to introduce my senior colleague, Mr. Desi Rodriguez. He kind of likes to be called Desi, but he's the lead in craniofacial neurosurgery, as well as does spine and every other pediatric neurosurgery. He was trained in India as well as in Newcastle, and it's an honor to have him. So first of all, Mr. Rodriguez will start the discussions, and then the second half, I will go through some of the results. Desi, are you happy?
Yes, I am happy.
Great, thanks.
Thank you, Naren, for your kind introduction. Don't say I'm a senior. I'm one of you. I'm a colleague. I'm sure there are much more senior people in the audience. But anyway, thank you very much. Again, second thing I say, Naren has said that my expertise in craniofacial. I'm no expert. I'm just trained to do craniofacial surgery. So I don't claim expertise in anything. A jack of all trades, master of none.
Just being humble as usual, Desi. Just being humble as usual. Thank you.
Thank you. Just to say, whatever we discuss is not something I'm pedantic about. You should not that I give an answer or someone says, even in the audience, someone says, it's nice to justify why you do it, what you do, and if there's any evidence to that, bring it to the fore. Okay. having a busy practice, I don't think any of us has looked at evidences close enough. But someone has got, please put it on a chat and share with us. We learn from you and you learn from us. And that should be the main aim of these meetings. We all share our knowledge and we move on together forwards. Okay, with that, let's start the discussion for today. Naren, I'll try to share my slides now. I hope I can. Host disabled participation screen sharing, it says.
Okay, just a second. I'll sort that one. Okay, you should be able to, Desi. Sorry about that.
No worries. Okay, now the questions are not in the same order which Naren had sent to you all. And so we've just reshuffled the whole order. Let's start with this first question about threshold of weight for shunting premature infants. Naren had asked if there was any threshold weight which y'all would consider, if there was a threshold to say yes or no. And as you see, majority of y'all have said yes.
Desi, could you share the PowerPoint, please?
Is it not being shared?
No.
Oh, sorry.
That's okay.
Okay. Can you see now, Naren? Nikos, can you see?
Yes, clearly, Daisy. Clearly, we saw clearly.
Thank you. Yeah, they can see. Thanks. Naren is in a different room. I'm in a different room, so he just came to check. Okay. So if you see on this, majority, 73.7% have said yes, they would have a threshold weight. In fact, it is 74% because even the one in Ember has said they've got a threshold weight. Whereas the 23 or 24% have said they don't have a threshold weight. Sorry, I'll just go back. Yeah. Okay. Have said that 24% have said that they don't have a threshold weight. Now, Naren, do you have the breakdown of those numbers, or do you want me to go to the next slide?
I think in terms of anyone here in the forum who doesn't have thresholds,
who considers that a threshold weight of anything less than 2 grams or even 1 gram, 1 kg, I mean not 2,000 gram or less than 2,000 gram. Any reason why you all would want to do shunting early?
So pretty much.
Is anybody putting a chat up? All right.
Anyone in the chat room, anyone here who has a different practice? Anyone here doesn't look at the weight? No, I think here everyone here seem to.
Okay. I would like to ask all those who are saying there should be a threshold. Why do you want to consider the threshold? You can just raise your arm, or you can just say you want to answer, put your mic on and answer. Do you think it is important, the weight, and why?
Nicholas, do you have any weight thresholds yourself or in your department?
Dear Naren, the sound is not good. I didn't manage to hear you well. Also, Des, I don't know why.
You can't hear us. Sorry.
I will try to get out and to get inside, perhaps again. Okay.
Okay.
Sorry, but I will go outside and then inside. Okay.
Okay. I see here, Erin. Erin, do you have, what's your threshold for weight threshold for inserting VP shunt in neonatal patients?
Hi, Noreen. Hi,
Hello.
guys. I would say that I generally, you have to look at why they need a shunt, I think is one of the big criteria. I said I would typically don't put a VP shunt in less than 1.5 kilos.
Mhm.
I typically use ventricular subgaleal shunts personally. And so somewhere between 1.5 to 2 kilos when their subgaleal shunt is failing and they have enough subcutaneous tissue, I'll put the shunt in. But it also just depends on the child's overall well-being and everything. So if they're still a critically ill neonate with bad lung disease and everything, I might hold off a little bit longer. So I would say probably somewhere between 1.5 and 2, depending on what the ventricles look like, if there's still frank blood in them, and the child's overall health status and skin tissue.
Yes, I agree with you, Irene. Basically, it is the subcutaneous tissue, the skin turgor, the baby's sort of overall well-being. And rightly, as it said, also depends, like Professor Klaas says, it depends on the type of a shunt, of course, and the valves. Some valves are bigger, and if you don't have the neonatal valves, then you are really in trouble. The skin is so stretched and it can break down. If you're going to use a CSF reservoir type of a shunt, where there is like the ricum, then I've seen skin break down, especially even on the scalp. So you consider the weight, and that's why we prefer weighting approximately 2,000 grams. Other thing is also waiting for the child to be more closer to term, because more premature the child, the chances of infection are higher. They develop NEC, we can again secondarily infect the shunt. Okay, any other comments from anybody?
Desi and Erin and anyone else, in terms of skin turgor, I mean, is this a qualitative judgment you make, or what would you mean by skin turgor and quality of skin for anyone who's new to this area?
Some of the children who are born, even if they are underweight, they have got good subcutaneous tissue and the skin looks quite good. Some of them are so flimsy skin, and you can literally, I've put a thinnest Bactocil shunt, and I can even see the shunt through their skin under their ribs. And these are the children you would like to put on little weight, put more subcutaneous fat, and then only put a shunt, because they are so risky. It looks like the skin is going to break down anytime.
Mm-hmm.
It's Erin. I would say the other thing to consider is how much weight is in that head.
Mm-hmm.
I had a baby just born 2 kilos and just massive congenital hydrocephalus due to X-linked aqueductal stenosis. And so when you have a really big head, most of that 1.8 kilograms is in the head. And then you just look at the chest wall and they're all skin and bones like that. That's when you have to throw your weight threshold out a little bit and say, we've got to get some real weight on this child. And that skin is stretched so thin over the frontal lobes that you do worry about putting the shunt valve there.
That's great, thanks. And Dan is here. Dan, what's the practice back in South Africa, and what's the practice in Oxford? Or what's your practice, Dan?
I think for us, the weight is mainly as a proxy for how well the child is. So in places like South Africa and the rest of Africa, whereby the weight is a determinant of whether the child is breathing okay, respiration is fine, they don't have other comorbidities associated with prematurity, they're able to survive the surgery, you have no issues with post-op care, then a rough 2 kgs was used as a rough cutoff for other issues. But as the other participants have said, it's also generally how well you think that the shunt will survive, whether they will erode or not through the skin, how good the skin is, wound healing, and factors like that.
That's great. Is there anyone in the audience who either waits for 3 kilograms or who even does it at 1 kilogram here? You can put it on the chat box if it is. You can put it later on as well. Anyone else has any comments to make about the choice of weight and the threshold, weight threshold for shunt in neonates in the chat room? Thanks. Des, you can carry on unless there's any more comments. I will.
I'll check what the next question is, because it would have been nice to have the temporizing device next, but let's see. Okay, we've gone to the management of neonate with obstructive hydrocephalus. I've seen that here. What would be your preferred method of management with children with aqueduct stenosis? When I say obstructive, it's aqueduct stenosis rather than anything else. So all 51.4 have said endoscopic third ventriculostomy. 48.6 have said that it is ventriculoperitoneal shunt. A good question to debate now. Those who have said, any of the group who have said endoscopic third ventriculostomy, what is the youngest child you have done an endoscopic third ventriculostomy on? Irene?
Erin?
Hey, Sarah. I think the youngest I've done is 27 weeks. And it didn't work. I got a flow void through the floor of the third, and it didn't work. If the parents really want to pursue it, I'm more than happy to offer it. But I tell them it's hard for me to take a child to the operating room when I know that there's an over 50% chance that the child will still be under pressure, and I'll be returning to the operating room within the next month. And so this is one time when I was talking with Jay Wellens and some of the HCRN members, that the utility of them seems to be 40%, the success of them seems to be about 40% or less in children under 5 kilos. And so now I've started really sort of using that as a bit of a threshold and trying to get them out of the neonatal period to a place where I feel more confident that I can do a successful surgery and treat their hydrocephalus versus doing an ETV, then still being under pressure until we decide it fails and we shunt them. And then that's 2 returns to the OR, in general anesthetic and a neonate.
If I may ask you, Erin, so you prefer to wait till they are above 1 month of age or longer?
I would say I prefer to wait until they're about 5 kilograms and healthier. So when they're past their lung disease of prematurity, they're breathing air, they're eating, they're feeding, they're gaining weight, and they're thriving. I really don't think it works well when they're still, intubated or in CPAP in the NICU, still being tube fed, still a critically ill infant.
Okay. I belong to the same group, so I would not have a sort of a strong opinion on endoscopic third ventriculostomy. I do tell them that there are 2 ways of managing. I give them the pros and cons, and I say that the failure rate is more than 50%, as rightly as Irene said, 60% plus failure rate. So if they're prepared to take that chance, reluctantly I might offer them, but I try to sort of go more towards a VP shunt. Anybody who's got strong objections to what I've just said, so could you just come up on the debate, please?
William Lowe, Will, do you have any thoughts? If you have the choice, what would you do? Well,
Has Will joined?
yes.
All right.
I think in terms of the obstructive hydrocephalus, the question is whether it's a functional aqueductal obstruction or whether it's actually organic obstruction. The functional obstruction become because of the large ventricle then causing obstruction of the large lateral ventricle, causing mass effect and causing aqueduct obstruction. Is that something that you look for, Desi, or is that something that I'm overlooking at?
Yes, William Lowe and I have done 2 cases actually recently of neonates who had a huge cyst which was obstructing both the foramen of Monro as well as, because of the dilatation, everything was pushed back. It was into the third ventricle coming right up to the foramen of Monro and causing an obstruction. Those while do well with the endoscopic, just fenestrating the cysts. per se, if there is a true aqueductal stenosis, you're quite tempted to do a ETV, but the failure rate is still high, or they do have re-stenosis. I mean, re-blockage of this. I've just got a child who I'm doing on Monday. I did an endoscopic third ventriculostomy for this child for aqueductal stenosis, 1 month old. He's come back with a blocked this because there is a membrane now I can see. I'd done a cyst because of the distended third ventricular flow. I could not see a membrane below. When I did a perforation, I could not see the membrane, but now clearly over time his head circumference has started going up and he's got a second membrane below which I need to perforate. So I'm bringing him for a redo fenestration of this membrane. Hopefully it'll work. He did very well for almost 2 months after the surgery.
May I say something?
Yes, please.
Naren and Desi, one of the patriarchs of the pediatric neurosurgery, Raimondi, in Chicago, United States of America, in the 70s decade, always said the neonates are not small childs, and the childs are not small people. Before you have to perform an endoscopic third ventriculostomy in a neonate, you must have a great experience in doing endoscopic third ventriculostomy. It's very important to have a great experience before you can try in a neonate. This is because my opinion, my personal timid opinion is to prefer a VP shunt. If you are not, if you don't have done much cases, at least, I don't know.
No,
in a neonate, it's very difficult. You have to have a desiderio, you have to have a great experience. I think you agree about that.
I absolutely agree with you, Nikos, because what happens is I qualified my statements that I'm in a neonate, I'm a proponent of a VP shunt. However, in a selected case, that's why I gave an example of a cyst and a complete aqueductal stenosis with a good third ventricular flow bowing, where I did. It is very few. I've not done a great deal. I would not do it in a neonate. Just like Erin said, I would wait for them to grow, put on weight, and then consider. I don't do it before they are past their neonatal period.
And questions to both Erin and you, Desi. If you are waiting for to pass the neonatal period, do you have a temporizing measure during that time, or do you just clinically monitor the patient?
Clinically monitor the patient. I'll go first. I clinically monitor the patient, and if they run into problems before that, I tell the parents that I would prefer going for a shunt.
Hi, it's Erin. I think a great example is I have a 32-weeker spina bifida that was born. And at the time of surgery, it was actually myeloschisis, so massive flaps that closed across his back. I put a subgaleal shunt in. He only weighed 1.5 kilos. I wasn't comfortable putting in a shunt, but I needed to I couldn't afford to have him leak beneath his back. And so I do temporize with subgaleal shunts. I think the other example is I did do 2 months ago, I did do an ETV and a spina bifida baby who was 2 months old. I waited. His parents really wanted one. I did a ETV at 2 months, and I'm actually going to put a shunt in him this morning. His ventricle's stabilized, but his Chiari-2 is getting worse. And we can't afford that, So I think it's always keeping in mind each individual baby and how healthy they are and how sick they are. And what we can do to help stabilize them. And then that is where I use subgaleal shunts.
And the comment that Nick raised was, in terms of the difficulty of doing an endoscopic third ventriculostomy on a neonate compared to a older child, in terms of technically, or in an adult, what's the difference? Do you find a difference in neonate compared to the older child and adult, both of you, or anyone else? Thanks.
See, working in a pediatric unit, I've not done adult endoscopies for almost now 12 years or plus. So
older children compared to older children?
I don't find much of a difference when I'm doing them because, we do babies, we do small children, so I don't find much. Go ahead, Erin.
I don't think there's much difference either. I think the one thing you have to take into mind, which if you do an endoscopic third ventriculostomy on a child with spina bifida, the foramen of Monro are angled differently. So if you're going to do one on a spina bifida, I would try to get some good pre-op imaging, either CT or MRI, that shows you the trajectory of the foramen of Monro, because you've got to have that to pass your scope all the way to the floor of the third.
Just to say, we are at Birmingham Children's Hospital. We are lucky. We use our neuro navigation for every case.
I personally use either neuronavigation or I use ultrasound as well.
Anyone in the audience who have any thoughts on this subject of neonatal ETVs? Please feel free to put your comments. I'm happy to bring you in. Thanks, Desi. Do you want to?
No worries. At this point, I would also say, please sort of interact and come on to the discussion. It's not between just Nikos, Naren, Erin, and myself, but I want others also to participate.
Dan, before we go, what's the you have been in different parts of the world now. What's your experience of ETVs in Kenya and in South Africa, and then now in UK?
I think technically, as the other guys have said, I don't find much difference in the neonates vis-a-vis the older adults. The main issues for me has been with the anesthetic concerns and with the physiological concerns. So things like in terms of incision, make careful, especially with trainees, to avoid bleeding, making sure, depending on the complications risk in terms of the cortical mantle thickness, depending on how severe the hydrocephalus is, and also just things from an electrolyte disturbance point of view and warmth and heating, mainly from the anesthetic point of view. Those have been the main challenges. In terms of variability from the different places that I've practiced, as you know from Benoit's papers, the flexible endoscope is very popular in many parts of East Africa, and that's because of a combination with CPC, which is a whole different controversial discussion. Hopefully we'll have time to discuss later. But with the flexible endoscope is the main thing that we use a lot in the small neonates, with the added capability of doing CPC. But otherwise, I think in terms of equipment and in terms of standard practice, it's otherwise the same.
Professor Moroto from Japan is here. Prof. Moroto, we are just discussing on neonatal neonates with obstructive hydrocephalus. What's your practice, Prof. Moroto, if you can join us? Thanks. While Professor Crystal, are you there? Hiya, Crystal, how are you?
Hey, just joining in. I just had to finish rounds.
Good, thanks. We have just been discussing on the second question. It's about the controversy about the neonatal obstructive hydrocephalus. And what's your practice on that in terms of ETV versus shunt? And if it is ETV, when do you do it?
I usually will wait on an ETV until they're 6 months old. So earlier on, I tend to prefer shunting.
So it looks like the consensus here in the forum is that people would rather prefer than rush in for a endoscopic third ventriculostomy, which absolutely, as we say, in selected few, if they've got an obvious reason, they might go for ETV. Otherwise, shunting is a preferred option.
Certainly in the group that we are here. Yeah.
You got anybody in the chat group asking things?
No, not yet. No.
Shall we go to the next question, Naren?
Yes, please.
Okay. Approaches in a neonate. Now, how many do a burr hole in a neonate? I mean, now let's not go to neonate. Let's go to children, infants. How many go for a burr hole and how many go for a mini craniotomy?
For ETV access. Yeah.
For an ETV access, yes. We've seen 81 say burr hole and 16.2 say that they are going to do a mini craniotomy, or rather, let's say 17% and 83%, isn't it?
Yeah, 81%. And
This is in the neonate.
I think that question we could reframe, because now the neonates is gone. We know that minority. Okay, neonates and infants. What would someone do if it was anybody above this, between 6 months and 1 year of age? Let's go to that. How many would prefer a burr hole, and how many would prefer a quick chat room answers? You have 2 minutes.
I haven't put the question yet, but can I ask from the backwards, Crystal, do you have any preference, Crystal?
I tend to do just a burr hole for an ETV.
Have you been in any practices where they do mini craniotomy for ETV?
Personally, no.
Right. And how do you open the dura? Just a linear incision or a cruciate incision?
Cruciate usually. I use a peel away sheath to just hold the tract for that. So I'll usually use a cruciate.
Okay. Anybody else who uses a mini craniotomy?
I was wondering if they would involve the fontanelle, yes or no, in neonates, because usually it is right at that area. So do you avoid the fontanelle, or do you do it very adjacent to the fontanelle, or do you really choose the bone lateral and in front of the fontanelle?
Thank you, Professor.
Orlando, who's asking?
It's Professor Grotten-Hughes. Thank you, Professor Grotten-Hughes from Netherlands. Desi, you.
I can tell you what I do. I do a small baby. I do adjacent to the this coronal suture, in front of the coronal suture, I do a mini craniotomy as big as my thumb. Okay.
Yeah.
I'll have to show you all my thumb.
If it is not a big thumb, no. But the thing is how to make a burr hole in a neonate, because the bone is still so soft. You can use a scissor. You can use just the tip of any kind of instrument to make the initial hole and then enlarge it a little bit. It grows very quickly again, so that's no problem. The point is, how do you close it afterwards?
That's what I wanted to tell you. What I do is I do a mini craniotomy, small one as big as my thumb. I flap the bone backwards on the coronal suture, because that suture is still fibrous, so I bend it backwards. Then I take the pericranium separately. Okay, before I do the craniotomy, peel the pericranium, do a small hole. Then I do a tiny flap of the dura, and then I make a hole and do a corticotomy.
That's very nice. That's very nice. It's more or less what I also do, because this is, especially because in neonates, the chance that the ETV will not be successful is rather high. So if it doesn't work, you easily get pseudomeningoceles if you just make a burr hole or a little flap. If you just make an incision, it will leak easily. So I prefer indeed this pericranium to cover it. And then actually I do the pericranium reverse from the skin flap. So that is the so-called double door.
Exactly, that's exactly what I do.
Okay, perfect.
In terms of the older children, the ones that I have done, which I followed the Birmingham technique, basically what Desi mentioned, but we do close the dura after the ETV as well, before we put the flap back the bone. Is that what you mentioned, Desi, as well?
Yeah, exactly. I open the dura in a small flap, so I can close the dura and reinforce it with a pericranium on top, and I put little tissel on top, and then put the bone back. I suture the bone back in its place, and then close even my incision is like a flap. So in case they leak, I can then use it to, if I have to put a shunt from the same hole, to put a shunt if need be.
That's great. Professor Neelam is here. Prof. Neelam, if you can connect with your audio, it will be good to hear from you. And Erin, do you have any preference?
Okay, I've got one question to the audience, and this is the technique which Mr. Lowe has kindly taught me after he joined our unit, of sealing the track. After I pull away the peel away catheter, Mr. Lowe has shown me the mushroom technique. I think, is Mr. Lowe in the audience? I think that technique has been published by you. Is it right?
Hi Desi. Yes, I'm around on call, so trying to do a few things. Yeah, it's a way to use a hemostatic or a graft or a material to block and plug the endoscopic tract that you've formed, which is quite big for a neonate or any children. And I'm sure neurosurgeons around the world would have their ways of doing it, and I essentially just combined all the little tricks that I've learned and into a technique, creating a little flap of the track at the end. So at the end of the construction of that graft, it looks like a mushroom or umbrella, so it doesn't drift back into ventricle. And it also means that if fluid does want to come out, it actually pushes the umbrella bit or the top bit of the mushroom against the closed dura, so avoiding CSF leak.
Hi, it's Erin. I really like that technique as well. So I always do three things. I make a curved incision at my ETV site in case I will be putting a shunt in later. I open the dura in a straight line so that I'll be able to close it with Proline at the end. And just like you're talking about, regardless of age, when I pull that scope out, I flatten a piece of gel foam out and I roll it, I guess, like a cigar, although I would not know. Roll it like that, so as it gets wet with CSF, it inflates and it plugs that hole up circumferentially.
Naren, happy to share my screen if anyone wants to see a picture of what I was
Naren, can I make a comment?
Please,
Neelam,
please do.
Yeah, I make a small curvilinear incision just away from the fontanelle. It will be about semi-circular kind of an incision. And what I do is that I carefully preserve the pericranium, and keep it as a layer. And the dura, I do a small, little larger burr hole. I don't call it a mini craniotomy. Little larger burr hole than the usual one, so that it will give little flexibility to move the scope. And then open the dura in a curvilinear fashion. And at the end, the corticectomy is plugged with the gel foam and put TCL on that. And then I close the dura, every time make sure that I close the dura. And over that, I also put the pericranium closure so that it will act as a double layer. And it also builds the pressure. It's very important that, you close it well. If there is a collection into the subdural space or into the subgaleal space, the intraventricular pressure will never develop and the ETV will not work. So that's my experience. So I stopped using the ventricular access devices because it increases the incidence of subdural collections along the peritubuli. And so I closed the pericranium also. It gives a very tight closure. So that will help maintain the intraventricular pressure to keep the ETV patent.
Thank you. Thank you very much, Professor Neelam. Crystal has a question for those who do the mini craniotomy. Crystal, do you want to ask the question yourself, please?
Sure. So part of the reason that I have a preference for a burr hole is I actually always leave a ventricular access device. I'll usually leave a ventricular catheter hooked up to a Rickham reservoir so that if the child does fail at any point in time, I can just hook that up to the shunt. I also find that it helps whenever they come back within kind of that early onset time frame if there's any concerns that the the headaches, that they're not really sure what's leaning to that, it's very easy for me to just do a tap of the reservoir to see if there's any concerns for elevated ICP. So I'm just wondering if you prefer a craniotomy, do you try and leave a ventricular access device, or do you leave nothing?
I personally don't leave anything. I just did exactly what Professor Nilam has said, and Mr. Lowe has shown that picture when he was sharing his slides. I used that technique.
In terms of, I think, you know, having the ventricular access device particularly is a good idea as well. You know, our Britain is a small country, so, you know, our patients are, you know, about half an hour away from, maximum half an hour to 45 minutes away from our hospital. But as in states, so if you have a practice with a very large geographical area, then I think I can see, you know, the importance of leaving a ventricular access device. Do you agree, Desi?
Absolutely. The thing is, I'm talking about our practice, because we've got not only the small area which we cover, we also have our nurse specialists who will be regularly in touch with the family. They've been given advice if there's any swelling over the operation site, or if there's even a drop of CSF which comes out from the incision site, they straight come to our hospital and going there. But we have to be aware of the other people from other parts of the world where this easy access might not be possible. So I think genuinely they would have to leave ventricular access device. Having said that, even in the UK, the practice is not the same. I know that some hospitals here do leave a ventricular access device.
Mr. Lowe, do you want to please share your technique and just talk us through it, please? Thanks.
Sure. I've just I think it's just gone off my screen now. Let me just show. Could you see that now?
Yeah.
So we tend to use the sponges stem that is the thicker version, perhaps the cheapest hemostatic agent that we've got. So we cut it in a shape like this and squeeze it into a smaller diameter, and slice the top bit here into 2 halves and flap it in. If possible, I try to get these flaps under the dural, in the subdural space as well, so that it's kind of an underlay in the dura. And what you will achieve, hopefully, is something like this. So the flap is right here. Even if there is a bit of leak going here, the fluid hopefully will just push the flap against the dura. Even if there is a gap, it will not leak. And of course, it also acts as an anchor, so that the chance of this whole tube migrating at all will be minimal. And that's the coronal section.
Thanks. Thank you very much. Very elegant, Mr.
And then a small comment on this technique. You know, if you put a longer sponge stem, you know, gel foam, sometimes in small neonates it's very risky. You know, there is a buckling of the cortical matter that happens along with that if you try to push this a very long piece of sponge. So what we do is that make it into small pieces and, you know, plug it. So it's little safer. It doesn't cause any damage to the cortex or buckling or a small chance of subdural collection, subdural bleeding. So what we do is cut into small pieces and plug the keep on gently. And at the end, if you put the steel fibrin glue at the end, it will hold and it will be sealed completely. It's only a different way of doing.
When you put small pieces, Professor Neelam, aren't you worried that the pieces might just go into the ventricle and then cause obstruction?
No, you don't need to just need to pack it superficially. Rest of the cortical mantle will come together anyway and block the.
Thanks, thank you. Before I go, I think for me, with the ETV, the main worry is the CSF leak. I have seen some disasters in my training and career. Professor Groton-Hughes, is this a similar techniques that you use as one that Mr. Lowe and Dr. Neelam has said?
Well, actually, I use more or less the same, and my residents call that the Nijmegen nail. They call it you nailed. But this is, of course, rather long, and that is for adults. So for neonates, that's a little bit more tricky to do, because actually we have one case where this, nevertheless, because it soaked up some CSF, ended up inside the ventricle. So this is, you have to be very careful. So I don't like to have it subdurally. I prefer to have it covering the burr hole and keep it there, and don't make the nail too long. But otherwise I do exactly the same. That's a very easy, quick way to cover. And because of the fluid, it swells a little bit, it closes it easily up. A very quick and easy way to close it.
Thanks, thank you. Mr. Rodriguez, do you want to?
No, I think that we've had quite a good discussion on this with a lot of participation. Let's go to the next. Naren, could you accept my slides? Or
if you, oh, sorry.
Yeah.
You should be able to share.
Okay. Lovely.
Good.
Okay, what is the next question? Let's check. Okay, for a VP shunt now, not for a neonate, for anybody. Location of the abdominal incision in children. Where do you prefer? Do you prefer it on the same side, opposite side, and if on the same side, which quadrant?
We have a difference in practice in our similar department, so I thought it would be a good question to have.
I think majority of them say ipsilateral upper quadrant. There is a fair amount of people doing it on the ipsilateral lower quadrant. When you say upper quadrant, what I mean is hypochondrium, and the lower quadrant is the iliac fossa, is it?
Yes.
Okay.
And
anybody in the midline? There are a few in the midline also, and some go from one side to the other. Anybody does the percutaneous technique? Just a stab incision and the shunt going in through a pillar catheter?
Hi, it's Erin. Fortunately, we have a very eager pediatric surgery department, and all my shunts are done laparoscopically, with the camera going in through the umbilicus, and then a tiny incision for the shunt to be passed in either the right or left upper quadrant. That's about 3 millimeters or so.
Thanks, Erin. I think, I had once got the general surgeons to help me. It was actually to retrieve a catheter that has gone into the peritoneum. But according to the general surgeons, actually doing the trocar, the percutaneous one, is easier than even doing the open one. And they encouraged me to come and join them. I hope I will do that. But have any of you actually learned to do it yourself, or is it you always get the general surgeons to do it?
I don't know exactly what you mean with the percutaneous technique, but I'm
talking about the endoscopic.
Oh no endoscopic. No, that is with general or pediatric surgeons. But making a very, at least in small children, you make a very tiny incision, but then I expose the fascia of and make a kind of nick in the fascia, and then I take a trocar to puncture the abdomen. I'm the only one. All the others don't like that technique because they are afraid that they could either puncture the liver or puncture the aorta or puncture anything inside the abdomen. In 40 years of practice, I have not punctured anything because you have to lift properly the peritoneum and then open that. So that's a very quick and easy technique to do. But I think the laparoscopic technique is really beautiful because you see what you do, and it is very elegant.
If anyone hasn't seen the one that they did in my hospital for me, was that they put a laparoscopic camera through the periumbilical incision, and then basically they used a very, very small incision and used a small small trocar from the upper quadrant, and then they inserted the catheter through that. It was very elegant, I have to say, and you know, you couldn't see it. I think recently some papers have been published on use of laparoscopic techniques for inserting the distal catheter. Obviously, it's better to just keep it simple sometimes, but if you can do it, it's nice. In terms of
sorry. Naren, yes, as you say, in our hospital where both of us work, you know, they have come. Most of the shunt incisions they do, we do are without laparoscopic approach, because getting a pediatric surgeon to come and give you a hand is a nightmare sometimes. For an emergency, they come only when there is a revision to be done, and when you say to them that it's going to be difficult, they stand by. Otherwise, getting them, they have to be free. They're always busy, so it becomes difficult. We've done quite a few, I think, here, and especially they have helped me free adhesions. They've helped me do it, but they have to do 3 holes, basically, one infraumbilical and one on either side, one for the camera and the other one for pulling the catheter. So, but one thing you can make out, as Andre said, you can see the CSF dripping. You're confident where it is being placed. That's very good. Like Andre's technique, my trainer, Alistair Jenkins, always used to do it. What he used to do is exactly make a small stab incision over the hypochondrium, go up to the fascia. Once he's in the fascia, small nick, and then through that, he would put a peel-away catheter and put the catheter in. So that's what I meant when I said percutaneous, not a true percutaneous.
In terms of, thanks, Desi, thank you. I will have to see this, it looks nice. In terms
Darren.
of, yep, yes, Crystal?
It's Crystal. I use similar to Andre. I use the Codman trocar that's made so that it's got an open portion on one side of it, so that you can actually thread the peritoneal catheter down once you enter into the peritoneum. And I find for most of my initial shunt placements that I've never had a problem with that. And it's you get used to the tactile sensation of poking through the different layers of the peritoneum. One of my adult partners here actually has a unique and laparoscopic, where he actually goes with the camera in a peel away sheath, so that he's actually able to visualize the area. So it's not a separate laparoscopic incision. I believe they use the initial one, and they use the camera get in with the peel away sheath, and you can see once they've entered into the peritoneum, and then they can use that peel away sheath to actually insert the peritoneal cavity. So that's actually a pretty neat technique that they've adopted here.
Me jalaste la sábana.
Just a second.
Es una pequeña venganza. Muy pequeña. Pequeña, muy pequeña venganza.
Yo me fui por mi cafecito y por lo único panecito que había. Luego a tener que, no, ya la pinche dieta ya quiero bajar.
Yo también.
Are we okay to go to the next? Hello, Naren. Can you hear?
Naren, you're muted.
Naren, you're saying, but we can't hear you.
Unmute yourself, Naren.
Thank you. Professor Moroto, can you hear me? No. I'll go back to the original question in terms of location of the abdominal incision. And I usually put it in the ipsilateral upper quadrant. And but you know, where I train, I also like to go across, because the hand actually moves very nicely when you move it for a ipsilateral upper quadrant without any problem. And in terms of, is anyone else here puts their abdominal incision apart from the ipsilateral upper quadrant? Professor Neelam, where do you put your abdominal incisions?
Well, ipsilateral upper quadrant.
Quadrant. And Professor Grotanius?
For me, the same. Although I, in the last couple of years, one of my younger colleagues convinced me to do it more peri-umbilical. I avoid the lower quadrant because especially, I know we are talking about children, but in obese adults, that has a higher chance of disconnection. And also that it can look like a scar from an appendicitis, which can give some confusion. So I would say most of my career did ipsilateral upper quadrant. I don't see any reason to cross the midline, to cross to the other side. So that's, but you see the variety is quite big, but the majority is doing that, 2 out of 3, yeah.
Hey, it's Erin.
Hi, Erin.
I was just going to say, one thing I do in neonates is I avoid the left upper quadrant because that's where their G-tube would go. And you never want to shunt really within a centimeter or so of the G-tube site. So I tend to go right upper quadrant in neonates. And then I have to go do a shunt now, so wishing you all the best of luck.
Thank you very much. Thanks for joining.
All the best.
And I think one of our the colleagues that I had worked, he avoids the ipsilateral upper quadrant or ipsilateral side because he's worried that he might go close to the nipple area, and in females particularly, that the breast development might be affected later on. Has anyone seen that?
Not really.
No. At least.
In fact, I use the right upper ipsilateral upper quadrant subcostal incision, which is much convenient than the longitudinal incision.
Βούτυξε καθόλου.
And anyone here does midline incisions? Mr. Lowe, I think you sometimes use midline incisions, do you?
No, I don't, Naren. Only when I'm revising my colleague Shunt, which already has a midline incision, but I prefer to go on the same side.
So the consensus, and Desi, would you say is on the ipsilateral side? Sorry, Desi, your mic is not on. Desi, we can't hear you.
We can't hear you, so closer to the mic.
Oh, sorry. As I say, today the consensus is ipsilateral upper quadrant, whichever technique you want to use, but and I to do the same. So we go with the ipsilateral upper quadrant as the predominant. Yeah. Let's go on to the next question.
Please. You want to move? Thanks.
Coming to the temporizing measures. Now, this is for a child with hydrocephalus or ventricular megaly of prematurity, secondary to hemorrhage. What are the various options we've enumerated? And he said, either do you all use external ventricular drains, serial lumbar punctures, ventricular access device, ventricular subgaleal shunts, just ventricular taps, multiple ventricular taps we mean, or endoscopic washout and then leaving a ventricular access device. If you see this sort of uniformity, not too many going to one side or the other, most of them are going for the ventricular access device. Some of them saying ventricular subgaleal shunts. But more or less not a big difference in the groups. So what was the forum here today? Let's start with Andre first.
Well, for already many years after a study of the neonatologist, we use ventricular access devices that even in the very small prams are placed in the neonatal ICU, so they are not done in the OR, they are not moved, it's a very short procedure, and we prefer that over regular lumbar punctures or certainly over ventricular taps. In the very early 90s, I have done for 3 years also a study with washout of the blood, but this is a quite severe procedure in the neonate and the prematures, with changes of the composition of the CSF in the ventricles, with the rinsing that is involved. So that was not a simple thing to do. Theoretically, that sounds very nice, but it didn't show any improvement in the outcome. So now we just do ventricular access device and puncture that in regular intervals.
Anyone, thanks, Professor Grotenius. Anyone else, anyone here who prefers ventricular subgaleal shunt? Prof, why didn't you go for ventricular subgaleal shunt?
Yeah, well, again, that's we did that after that study with washout and the endoscopy, where you actually needed at the end 2 accesses to make it a safe procedure. And then we thought maybe the subgaleal shunt. The problem is it didn't function so well. I mean, the subgaleal space, if you look and do it properly, is unlimited. It really can take something, but you have to dissect it with the scissors, and you have to say we are talking about the prematures. This was I had much more wound problems based on that. So actually after that, we returned to the lumbar punctures, and then after the study in 1999 and 2000, we did the ventricular access devices, and that we stuck with that.
I've done a couple of subgaleal shunts. I didn't have any problem, but the head becomes like a bag of water outside. And of course, the only difference is you don't tap them frequently. You only tap them if they're needed. So I did only a couple, and I went back to ventricular access device. Now, if you see the literature, there was a meta-analysis done by Fontaine et al. In 2016, where they looked at 338 publications, of which only 5 met the criteria. And they have shown that there is no significant difference whether you do a ventricular subgaleal shunt or a ventricular access device when it comes to rates of infection, needing a permanent shunt, and others. The only difference is that you might reduce the number of taps you might have to do. So I don't find that there is much significant difference between ventricular access device and subgaleal shunts.
The thing is, what at least for us was that who is taking care of these children? And very often these people had no idea what we really did when we had a ventricular subgaleal shunt. They were said, oh, they have a VP shunt. They were simply not aware of what we had done. If you have this ventricular access device, it sounds silly to say this, but that was clear. It was made clear. The neonatologist would puncture that, or we would come and do this. But the ventricular galeal shunt, because you don't puncture them so often, and as you say, the head is swelling around. The parents are frightened. They and also the nurses. And I mean, that is the daily 24-hour routine in a neonatal ICU. We had much more phone calls. I can tell you about the frightening side of it. And as I said, maybe we did something wrong, but we had somewhat more wound breakdowns and infections. So that's was probably our local problem.
I totally agree. We also have a similar experience, wound breaking as well as the parents' anxiety. In fact, ventricular access devices, next time you don't need to puncture the ventricle at all. You just need to remove the top cap and connect that to the shunt. So that becomes an advantage.
Yeah. Thank you very much. Anybody else?
Professor Dear Pujari has kindly joined us. Prof. Dear Pujari, it's a great honor to have you.
Joined in a little late, Narendran, but thanks. We are actually trying to shift to ventricular access device because of the problem that in spite of being very, very strict about, ventricular access device being tapped, we are finding that we are getting more infections, and that is something which we have been able to curtail with the use of a subgaleal shunt. So whenever we usually put in a ventricular access device, but if it has to be used beyond 3 to 4 weeks, then we convert it into a galeal shunt till the CSF is completely normal or there is no other contraindication to doing a permanent CSF diversion procedure.
When you use the ventricular subgaleal shunt, is there an increase? Do you find any increased risk of multiloculated hydrocephalus later on? Do you see that as a phenomenon, or it has not been a problem?
We haven't particularly looked at this, but memory-wise, I don't think this has been a particular problem which we have noticed. But if you keep any kind of foreign body in the ventricle, I think it can probably make a person more prone to have multiseptate hydrocephalus if the CSF is not completely normal. So it can happen, I suppose, but I can't give you a definite answer to this question.
Naren, we never had any problem with the ventricular access device. I can tell you one more technique. If, as Dev Pujari is suggesting, this
Sorry,
device.
Professor Neelam, your audio is not coming through.
Sandeep Chatterjee sold on the idea that we must use ventriculogaleal shunt, and he finds a remarkable difference in his practice. He or Kaushik are not here, I think, in the participants today. Otherwise, they could give a comment.
Thanks. Thank you. In terms of Crystal, what about your Crystal? You're there.
Yeah, we use ventricular access.
Yeah. And what's the consensus? Is there a consensus in states, or is it also kind of a mixed bag in terms of ventricular access devices versus ventricular subgaleal shunt?
I think it's a mixed bag. Some places, I think Hopkins, I've known some folks who've been out at Hopkins, they used predominantly subgaleal shunts. So I think it just is a matter of what you were trained on.
Great, thanks. Suhas is there. Suhas, what's your experience from Kerala?
Hello.
Hello, Dr.
Yeah.
What's your...
Yeah. I use a ventricular subgaleal shunt often.
Mm-hmm.
I use a ventricular subgaleal because the idea is if the child needs to be sent home, I can send the child home with ventricular subgaleal shunts. That's an advantage when you have a BSG.
Can I ask a question to Suhas, please?
Yes, go ahead.
Suhas, when you do a ventricular subgaleal shunt, where do you site the play? You put it from the frontal, definitely, but
frontal.
Parietal, or do you go to the opposite side, where it has to drain and make a pocket?
I create a pocket all around, whichever is all the spaces that is visible, both sides and frontal. Not frontal. The forehead is spared. The rest of the areas I create.
So both bilaterally parietal and parietal.
Yes.
Because when I used to do it, I prefer it to go on the opposite side, parieto-occipital, quite a big pocket.
Yes. You get the big access, and I think the best advantage is you don't have to access it anymore. And I mean, none of the personals need to access it. That's the best advantage.
Fortunately, in India, if you tell them that it's not going to look good for a few months till you get rid of this, they accept it, I think, more readily than what Andre had just described.
Yeah.
And anyone here has had a extended EVDs, long tunnel, as in coming out of EVDs that come out from the thorax or more from the abdominal exit. Have you had any long-term
Yeah.
EVDs, long-term EVDs, any of you?
Yeah, I had long-term EVDs up to 3 weeks where there was any problem. The technique what we do now is try to take the lower end as close to the abdominal incision as close as possible. So the long is longer away from the cranial part. It's safer, and you can keep it for a longer period of time.
Naren, as you know, I've used it just like Professor Nilam says. I have used it for ventriculitis, where we had to treat with long-term EVD, where I put a recum, connected it to a long catheter, tunneled it right down by the side where the abdominal catheter would come, but go a little distally and put it further so that you can then use it as a tunneler to bring the new shunt.
Right.
Absolutely.
Thank you. Desi, do you want to move to the next question? Please.
Okay. Tools for third ventriculostomy. Okay. We've seen a lot of things here. I'm just reading through this. Anybody who uses different, how many, does everybody use a peel-away catheter, or y'all do without a peel-away catheter in children?
Without a peel-away. Without a peel-away.
Y'all don't use a peel-away.
Well, it is difficult to procure and it is very expensive. So we usually don't use it.
There was one, especially in children. This is a very short procedure. And I always remind people what Alan Cohen, at that time still in Boston and later on in Cleveland, told me. It's doing this with the bank robber's credo. You go in, you get the money and go out. So that's a short procedure. Don't make it any more complicated. So you have an endoscope, an instrument. Don't do any sightseeing inside. And you are finished the whole procedure within 10, 12 minutes. That's a maximum. And that's the easiest way to do. I still know from Charlie Theo, he is using the endoscope itself, and it's not, oh yeah, it is mentioned here. Yes, it is mentioned that. And also, but he used the optic, the 30-degree optic in a certain way, and then push through the floor. So there are many techniques, but no other things. No, sometimes you don't even need rinsing. It's such a quick procedure to do. If you don't use rinsing, you see if there is pulsation of the floor. If you rinse, you don't see it because the rinsing will keep it in one direction. So it's very quick. Make it as simple as possible.
And what do you use to perforate the flow with?
Well, I use my own instruments that are actually since 2 years not available anymore. I developed what is called the perforator and dilator. So because I saw that initially when the floor was already very tough, I had to push quite a bit with any kind of instrument, the balloon catheter, which I used very often, not the figure of 8, but regular Fogarty, any kind of instruments, forceps. And I sometimes saw these little petechiae on the hypothalamus just because I had to push all that way down if it was tough and to open that. So I developed this suction device that lifts up the floor, and by turning it around, inside there's a kind of little corneal trephine, and you have an initial opening. You let it go, you have this tiny little opening. Then I have a kind of, well, spreading instrument, what is called a dilator, and I just dilate in different directions that initial opening. So I more or less never go with an instrument into the interpedicular cistern. So if I'm finished, I go with the endoscope towards that opening, and then I have a perfect view or if there are second membranes, more arachnoids, adhesions, and so on. I can tell you that in the very beginning, I did ETVs just by going with my endoscope. There was often a flexible endoscope, all the way to C1. I wanted to go the whole way down the clivus and the whole area and all the nerves there and then see, oh, now I see one, that's fine. I don't do that. I certainly don't do that anymore. That was the excitement of the very first moments and the first experiences that we have. Make it as simply as possible, but make it effective. So you know what to do, you plan it, it is from the opening, the burr hole, to the area, make that opening, make it an effective opening, see that it is pulsating, go out again, and then close it. That's it. And anything you use there, no sharp things, no laser, no cautery, nothing, no thermal, no anything. It's not necessary at all. That's my experience.
Professor Grotten, thank you very much. And what about, I'm sure you probably assume it in your answer, but do you go to fish out the membrane of Liljeqvist and look around for that, or you just see the pulsation and come out?
Yeah, because of this lifting the real floor of the third ventricle up and then opening that, usually because in hydrocephalus, the Liljeqvist membrane is very close to the floor of the third ventricle. If I lift only up the floor, that membrane is still there. So I usually had to open again that membrane. So that's because if you push down, you push immediately through both of these membranes in most instances, and you don't have a clear view of that. In my technique, you lift the real tubucinarium, the thinned out tubucinarium, you lift it up, you have this opening, and below that, there is still this membrane. So you are sure there is this membrane, and you make sure that you open that membrane. And then you have the view to the basilar artery. You see that it is not subdurally, because sometimes if it is very close to the clivus, I have this little trick that if this is it's a very narrow interpeduncular space, I make the initial opening with that instrument on, not near, on the dorsum sellae, because that's bone beneath. So that's safe, will not bleed. You have that opening. Then you take a little hook, you pull it back, and you go into the interpeduncular area. Then you are safe. Because the moment you have to make that opening, it is still subdurally, you pull it back a little bit, it starts to pulsate. Then you know you have made a good, what we call ventriculocysternostomy. So you really are in the cisterns and not somewhere epi-arachnoid.
So, dear Pujari, what's your technique?
The technique had changed a little bit. Earlier, when we had only the adult scope, which we used even in children, it was, number 4 Fogarty catheter has a stylet. So usually the catheter itself was good enough with stylet, and then we would remove the stylet after we made the hole and then inflate the balloon. Then later when we got the pediatric scope, and now we are using number 3 catheters, and number 3 does not come with a stylet. So we started using I use typically a bipolar without connecting it to the energy source, and use that to make a hole. And then I push in the balloon catheter, the Fogarty balloon catheter number 3, to widen this opening. And I also use this thing which Professor Grotenhuis has initially taught us to pinch the floor up, especially when the opening is small as he described. But rather than using the hook, I use the scissors to make that backward incision to create the opening, if at all I go subdural.
That's great. In terms of, sorry, I might be it was just me. When you say subdural, what do you mean by that? You just say that you just open the arachnoid and go into the subdural space, is it? Is that what you are meaning?
Well, when you open the third ventricular floor, if you are too close to the clivus, then you have a possibility that you can actually be extra arachnoid.
Yes.
And you do not actually get the flapping of the membrane. You can actually see that there is probably a little opalescent membrane, and then you need to open. So either you make a second hole if you think there is enough space, or then back cut it in some way.
Thank you.
Is that correct, Andre?
It's absolutely correct. Well, the thing is, it is not really subdural. It is what I call epi-arachnoid. So it is above the arachnoid, and there is still a layer. So you're not really but it is, yeah, I would say so, because if you go back and open that arachnoid, you are really in the cisternal space. But I fully agree with you. Sometimes if you do it too close to the clivus, you are not in the cisternal system.
That's
right. Not in where the CSF is circulating. That's so important. And also that, well, you know that I promoted that already many years, because this will allow the CSF to flow back from the cisterns to the ventricles. You know that I'm not believe that the CSF is going from the ventricles to the cisterns. It's reverse. But okay, that's a complete different topic. I will not go back into this further. But that's the technique I will. I absolutely prefer. But if you see that list, it is so nice to see how actually the DEC forceps. It's only one person using it. I know that it is.
Yeah.
Made for the storage equipment, but such a beautiful, simple, elegant instrument to deal with arachnoid that will not slip away from you because they have the little grooves on the outside of the forceps. Elegant, very elegant.
Thank you.
We use that sometimes. I also would say that to complete the list, I know for a fact that the Taiwanese neurosurgeon, Tai Tong Wong, he uses the Dormia basket, which people use for ureteric stones.
And
So
I have used that. Actually, I have used the leucotome very initially in the 90s, and that's. But no. For me, these are a little bit too sharp. The wires of the basket are too sharp. I think I have more or less used every single thing that was mentioned in this list somehow at some time in my life to improve.
Crystal, do you want to say anything for the American side of things, and your side, and for the American practice? Crystal? While Crystal is owning. So I think, Desi, any comments from your side? I'll get the.
Yeah, we have covered, I think, the topic, and thank you very much, Professor Deopujari and Professor Gratis, for both enlightening us, and that was very helpful.
Thank you very much, Desi. I'm just going to go to the second part, and it will be quite gallop. But before I go to that, one of the things that I find, one of the questions I had in the survey was on when you are revising a VP shunt, how do you assess the distal catheter is patent when you are opening the when you are revising from opening just the around the valve? The answers were so varied that I couldn't even put it into a table. And the question is that I use a manometer. I connect the manometer to the distal catheter and then see how it flows. But the question is that at what point should it flow all the way down? Would the fact that the patient is having anesthetic, does it mean that the manometer would never go all the way down? And is there any way that, Professor Deopujari, is there any fail-safe way that you'd check that the distal catheter is working just from the opening the upper incision?
Not really. I really am not aware if, unless you see the flow, I don't know how else can we
sure.
Just
Yeah.
to
The
first,
only other way we have tried a couple of times, I mean, this is before coming to surgeries, we try to do a USG of the abdomen, and at that time we push the shunt chamber to see if any CSF is flowing. And the other way is probably you can do a laparoscopy and check similarly. But I don't think when you are actually doing upper abdominal incision to check, there is no way unless you get to the tip.
Thank you. Professor
I
Gautam,
don't know if I understood the question correctly.
yeah, I think you have answered, Prof. You are absolutely. And
Yeah, the
Professor,
surest way to find out is to pull out the lower end and see the flow clearly. Otherwise, many a times, all techniques, including pushing the saline, everything has failed, gives a false impression sometimes. There can be a loculation in the abdominal area where the flow can be pretty good. And then you put back and again you have the same problem within a week. So the best way is to pull it out completely and then reposition.
Thank you, Dr. Neelam. Professor Groton-Hughes, do you have any wisdom from your have you ever had that you thought that you had?
That you should, if you pull it out, and I know that the younger ones don't like to do that because they are afraid that it is difficult to get it back in again.
Yeah, yeah.
But no, you have to get it out. You know there is a good flow. That's the difficulty. If you see a little drop, and then after a few seconds you see another drop, and you see another drop, is that sufficient? Yes or no? We simply don't know. It is about the positioning of the head or of the child, if it is in Trendelenburg or not, and then so this is it's not an objective measure. And as you said, if there is an abdominal problem, if there are pseudocysts inside, yeah, well, then you have, of course, if you bring it into one of these cysts back again, within a few days, 2-3 days, all the symptoms will recur. So that's, but I don't think that a manometer in the proximal end will help and will help to make these decisions. The same is with all these subjective measures as, oh, I flushed the shunt. I know some of my colleagues that they always do that. When they revise a shunt, they take a syringe and then they flush it completely. And they say, oh, now it runs more smoothly. Come on, that's all very subjective. That's the difficulty. I think that the abdominal side of the shunt is still, and even the cardiac side, is still the least understood. We know that when the child grows, and certainly in adults, the intra-abdominal pressure can change a lot. We know that it plays a role in obesity and intracranial hypertension in young female, usually obese female patients. That's a problem. Shunts don't work because in the abdominal compartment, the pressure is too high. How is that in children? We operate them supine. But when they are running around, when they play, when they jump, when they are sitting behind, maybe at school, sitting behind the screen, what is happening with the intra-abdominal pressure? We simply don't know. I'm now happy that I don't use any shunt anymore, like very early on that you could pump. You could pump yourself. I can tell you, there was these patients that pumped themselves 250 times a day and then complained about headaches. Well, that's the difficulty. We now have the gravitational devices. They are smaller. You can't tamper with them from the outside. Why do we have the possibility of external measurement of the pressure with devices? We simply don't understand it so well anymore. An abdominal, most tough part of the whole shunt system. And I'm not speaking about the ventricular part, and that 40% of all ventricular catheters never end up in the place that you intended to bring them in. So The thing is, nature is mild and it still works. But the abdominal part, Naren, is tough. If you have proximal obstruction, it's more easy for us as neurosurgeon to solve. The abdominal part, if you start having problems with that, that's the start of multiple revisions, unfortunately.
Thank you. Just one of my, one of the consultants that I had worked with, he once said to me that when you press the abdomen, if the fluid comes back, then you can suspect that there is pseudocyst. Have you ever, do you have any comments on that observation, or do you think that's once again
that's not fully true. Sometimes you have, it is not a real cyst, but you have some of these situations where the resorption of the peritoneum is simply insufficient. Maybe it is insufficient because of the high amount of fluid that is produced. But usually these are after early surgeries in the neonatal phase that they had in the abdomen. They had already a gastroschisis, or they had any kind of developmental problems in the abdomen. These are the tough ones. I remember one case that I did 36 revisions in the first year of life, then ended up with because he had also cardiac malformation, so ended up with a pleural shunt, one of the very few I did, and that had a hemithorax fluid. So when that child grew, when he was 3.5, we finally could put it back into the abdomen and it functioned well after since. But the thing is, this is a dynamic that we poorly understand. So I think just putting on the abdomen is well, again, this is one of these subjective signs that we love as surgeons, because it gives us a sense of we know what to do. For me, it is not a sure sign of a cyst, and usually I'm very strict in using contrast and in imaging, because you have to show that a simple ultrasound is not sufficient, not sometimes even an MRI scan. Same with multiloculated hydrocephalus in the ventricles. You don't know what is communicating, so use contrast. The same is use contrast that it is pushed down, and you will see in the abdomen if there is a collection, yes or no. Personally, I think that is underused in neurosurgery to diagnose this problem.
Thank you very much. That's a great point. I will go on to the second part, which is, I'll just share the screen with you. Great. Great. Can you all see the my slide there?
Yes, Naren.
Great, thanks.
Yes.
So this is the results of the second survey. This is on use of different valves. So I think this is an old chestnut, but it's nice to know where the current thinking is. And the thing is that the reason I'm doing this meeting is that sometimes when you are working in a department, you can easily just do what your seniors are doing, what your departmental policy is, and you might not be open to other ideas. And it's nice, sometimes nice to put your head out of the window and see what others do and their reasons. So please, I look forward to your comments and what you call. So the first question I asked was, which valve do you use in neonatal hydrocephalus? And sorry. So I got 69 replies in the last 2 days. and the majority still use fixed pressure valves. But there's quite a good number also use programmable valves, and programmable valves, and some use the gravitational valve. I thought it would be more, and some use the flow regulating valves. And I use fixed pressure valve myself, and I use the Medtronic 1.5 Delta, and most of the time it works absolutely beautifully. But then I do see time to time patients with small ventricles, even with a 1.5. So, my mind always wishes whether I could go to programmable or not. So the second question, so this is again showing that the majority still use fixed pressure valve, but programmable is not far away. And obviously this is a small sample, and there's a lot of biases in these things. I want to know, anyone here uses the programmable valves for neonatal shunts in the forum? Prof. Dio Pujari, have you used programmable valves in neonatal settings?
So I think a little difficult for me to answer, because our current feeling is that most patients would get a fixed pressure valve, and if possible to use antibacterial coating shunt, but they have again become unavailable in India right now. I would suggest programmable shunts usually as a second procedure if the patient has a problem with the primary fixed valve. And any child above the age of 3 months, I would give them a definite option, or in fact, I would prefer to do a third ventriculostomy whenever possible.
Thank you, Prof. It's Elias, is it Elias, Dr. Risk there on the forum? Crystal, do you use, what kind of valve do you use in your practice?
So I use programmable valves just so that I can adjust the setting as I follow their head growth. I'll usually start at kind of a middle of the road setting and then watch their head growth and adjust them up to the highest pressure that they'll tolerate, just to prevent theoretically the craniocephalic disproportion that we can see in these patients. And I've gravitated towards the Medtronic Strata, but I don't necessarily, I think that was just convenient. It's easy to program on wiggling babies. So I tend to prefer ones where you don't have to strap the kids down to get them reprogrammed. And I don't like any that require the X-ray to confirm following. I prefer to be able to confirm with the programmer itself, just to try and avoid the excess radiation that these kids get.
Thanks, Crystal. The question is, at what setting do you start, and when do you decide that you go up the settings?
I will usually start, since I use the Strata valve, I'll usually start at a 1.5 setting. I exclusively use the Strata valve with the Delta chamber siphon guard to prevent over drainage. And then I'll follow the kids early on. I'll see them about once a month to follow their head growth. If I see that their head growth is tracking on an appropriate trajectory, then I'll leave it alone. If they start to drop percentiles, or if they're well above the curve and they start coming down so that they're in the middle, then I'll actually start dialing them up. And then likewise, if their head trajectory continues on the higher end, I'll start to dial them down. So I predominantly will avoid imaging early on, and I usually will get another baseline scan once they've been at a stable setting for several months with an appropriate head growth at that setting.
Thanks, thank you, Crystal. Elias, can you hear me? Would you be?
Hey, Naren, this is Elias.
Hi, Elias. What's your practice at Penn?
It depends on pathology, age of the child, and what's the ultimate goal or need for the patient. Somebody who has maximum hydrocephalus and you need to slowly bring down the ventricular compartment, you probably need to do a programmable valve. And there's more meta-analyses coming out now that programmable valves seem to last longer than fixed pressure valves. So I agree with Crystal. You know, maybe in your practice adjust this, but the valves that we have and that in the market work when gravitational pull or siphoning mechanism, whatever phenomena you want to add to the system, does not work when the patient's upright and depends on pressure compartments that you described based on different body habituses and body sizes and adjunct diseases that they have. So it's an art, and guaranteed you're going to have to consider revising somebody either in the short term and the long term. And I feel that the longer the patient survives without a shunt revision, it becomes more difficult later in life to do a shunt revision, because for some reason the physiology changes, especially if you change the valve setting that they have before. So it's an intricate art, and it takes a lot of trials and tribulations sometimes to figure out what's the best thing for the individual. And you know, from India, you know, with the devices that they had, you know, they did and continue to have good outcomes with the basic ultra-Habra shunt. And you go through the most sophisticated shunts here, and you still have patients come in with complications, subdurals, collapse of ventricles, or under drainage or over drainage. We did benchtop testing of all shunts here, and changing or adding 15 centimeters to any device sometimes can bring the negative pressure inside the system to minus 20 to minus 40 millimeters of mercury, when the additional 10 centimeters of height is added to the system when the person, for example, stands up. So the systems that we have are not ideal. They don't perfectly work like we intend them to do. They don't reproduce the natural physiology. So, you know, this technology is 100 years old, as everybody knows. We haven't really come up with something physiologic to reproduce what we have in the brain, and that's unfortunately what we have now on the shelf. So I won't fault anybody that chooses one valve over the other, because, you know, sometimes it will work beautifully for 90% of your patients, but then, you know, that 10% continues to have a problem. Slit ventricle syndrome, prematurity, IVH, infections, maximal hydrocephalus, all these will come to your practice, and you tend to have multiple shunt revisions in those subpopulations.
Thanks. Thank you very much. Just going back to Crystal. Crystal, you don't find the programmable shunt large profile in a neonate?
I haven't had an issue with my neonates. I usually don't shunt them until they're 2.5 kilos. I give them a little extra time just to get bigger. But I haven't had any problems. The kids that I've actually had problems on as far as skin breakdown have been the congenital hydrocephalus kids, where they're born with like a 49 centimeter head, and it's just a matter of they've already have so much tension on their skin. But for the preemie IVH kids, I've not had any issue with skin necrosis.
Thanks. Professor Grottenhuis, your thoughts on programmable shunt in neonates?
Well, I think it has already been mentioned that programmable in a neonate. I mean, a neonate is not walking around. So my feeling was a fixed pressure for the first year is the easiest way to go. Personally, actually, I was one of the 4 using gravitational valves. We have this Paediatric, the gravitational ones, and it's very good. My personal experience with programmable valve was that too often with minor changes in the clinical situation, there was this urge to start changing the settings. And second was indeed, but it has been mentioned, and apparently Crystal doesn't have that problem. I saw that the size of these all different kinds of programmable valves is still rather big compared to the head of a neonate, and especially the thickness of the skin. So personally, I had seen some skin breakdowns, and I didn't like that at all because this adds a lot of additional problems. So and therefore I don't use the programmable gravitational valve because that's also available. And the advantage of that is that you don't need scanning, X-rays, and constantly making an X-ray to see what the setting is after you changed it. So that I fully agree with Crystal that I want to have that with my own system that I can check that. Later on in life, yes, I would certainly do that. But we were talking neonatal hydrocephalus. And for me, I would say the initial part would be just, but then I would say we talk about fixed pressure. My residents always ask me, what fixed pressure should we take? The low, the medium low, the medium high, or the high? I can tell you this gives already a lot of discussion. So I'm wondering what the people are using when they say fixed pressure, because this is not one pressure that we are talking about. This is a whole series of possible pressures. So you see, this is not easy. I always loved during the training course of the ENS that I, together with Marianne Euler from Denmark, we gave this 2-hour discussion group on how to choose a shunt. I can tell you that was a fun thing to do because it is so difficult. And the majority of answers that we received was, what kind of shunt would you choose? Well, I would choose the shunt that my consultant is telling me to use. That was the most common answer at the beginning of the course. And then at the end of the course, they understood why they were choosing the different pressures they were choosing, depending on what we are dealing with. So it is a really individual choice. The same is with any kind of anti-siphon effect. And there is no one shunt that fits a neonate, a toddler, a school child up to adulthood. I tell the parents that we have to adjust the type of shunt and a shunt itself, and maybe even when they are older than 2, think of an ETV. So all this needs to be a consideration. And that's the last thing I will say. It's also a matter of price, because here in Europe, we can have any kind of, like in the US, but in many places in the world, they simply will never have the possibility to even think of using a programmable valve. That's all I wanted to add.
Thanks. Just 2 questions on this area. One is that, I have worked in one department a while back where, one of our commonest operation was shunt valve upgrade. And, in terms of ethically, is it ethical to put a kid through another shunt valve operation or put the patient through a programmable valve? Any thoughts on that, Professor Grottenhuis and then Professor Diapujari and Neelam? Thanks.
Yeah, of course. I think that the one point is certainly right, that if you can avoid any further operation on any of your patients, so try to do it the best from the beginning. I doubt that the programmable valves are really suitable for that. Unfortunately, they are all just differential pressure valves. They, if you choose a higher setting, that's still differential pressure setting. It is not adjusting to the changing physiology of a growing child. So most of the times you will not avoid another surgery. But I think the adagium is, of course, try to do it all with one surgery when you deal with the shunt. That would be our ideal. Place a shunt in the very early time of life and never have to do any kind of surgeries at all. That would be the best, because any surgery is involved with complications, but the chance of having difficulties. I find it difficult to say it is unethical, because I have done, therefore I'm reluctant to say that, I have done some elective revisions in 4 or 5 year olds to change the whole system, at least the whole valve system, to another things that I was convinced that they would take longer up maybe adulthood to have a functioning shunt, and have done that electively. So not waiting for the acute moment of a shunt obstruction that usually comes on a Friday night, and then the rest of the call will do that revision and justice. So that's the issue. I wanted to have this as a kind of thought process of trying to deal with hydrocephalus. And of course, I'm thinking about that completely differently than 30 or 40 years ago, for sure. But yeah, I don't think that our programmable valves, like they are now there, are avoiding other kind of surgeries in the future.
Thank you very much, Professor Gurtridis. Professor Diapujari, do you think programmable valves would avoid slit ventricles?
Well, they are supposed to do that. Doesn't always happen though.
Mm-hmm.
And we have to keep on adjusting pressure as whatever my limited experience is. We we don't revise anybody's shunt electively. In fact, early part of my career, I used to get a lot of references from pediatric surgeons who used to put shunts in childhood earlier. Even today, we have some people still doing that, but now it mainly comes to neurosurgeons. But 20 years ago, it wasn't the same. And most of them used to tell their patients at the age of 5 years or 6 years that you have outgrown your shunt and you should now get it changed. And they used to refer patients to us. That is not happening anymore. The other thing, which I don't know how we have no statistics to prove this, but I think we are not cutting the shunts as we used to do earlier when we first time put the shunts. The abdominal catheter, we don't mind if it is long. So probably therefore they are more longer lasting. And I have a feeling that because you use a long tube, you probably have sufficient resistance, which allows you prevents over drainage. So I think it helps. The length of the abdominal or the distal catheter probably also helps in controlling the pressure in some way. So electively we don't, unless the patient is symptomatic and we have some imaging evidence that it is over draining or under draining.
Thank you. Just a question to Dr. Neelam. Let's say that I have now got a 2-year-old child or 2.5-year-old or 3-year-old child who had initially put a 1.5 medium pressure valve, now has got a very small looking ventricle and pretty full head, but no particular symptoms. By putting a programmable valve and jacking up the pressure, is it going to actually change anything in terms of the head growth, or is that all over now and we just have to manage expectantly? What's your thoughts on that?
Yeah, absolutely. It's very disappointing with the programmable shunts. So I totally agree with Andrew and the Pujari that I will not disturb the shunt unless it is really warranted. No elective interventions as far as the shunts are concerned. Even if the child has slit ventricles and asymptomatic, I'll just closely follow them up. I will not do any intervention at all. If they really come back with a significant symptoms, then probably we'll try to manage the symptoms for a while. They settle down because these the elasticity of the brain keeps varying with time. And if you try to do a manipulation at that point with a programmable shunt, again, you are introducing another change, which may not be good at all. So this is my experience. So I just follow them up. If it is really inevitable, then we have other options today, like using endoscopy or other options. That would be much better than a programmable shunt. One is the cost. The other one is it's not really assuring that we can really be able to program the shunt effectively.
Thank you very much. Sorry for persisting on this question. Crystal, do you still have any slit ventricle syndrome with the patient that you are using programmable valves?
I've had one kid that has developed what I think is slit ventricles, but every time he's failed when I put in an EVD, he's a 6-year-old, and with an EVD at 15, he's putting out like 500 to 600 cc's of CSF. So I don't even know how he's making that much. But I haven't had that many kids at this point, but I've only been in practice for 6 years. So I don't necessarily know that I'll start seeing my own little cohort of slit ventricle kids quite yet. I do have several teenage patients that had initially had medium pressure valves that have since developed slit ventricles. What I found is in these kids that I never voluntarily change the type of valve that they have when they come in and need a revision if the valve is malfunctioning, unless there's an indication. But I found that converting kids later in life from a fixed pressure valve to a programmable valve becomes not only incredibly difficult because I think you've changed their hydrodynamics a little bit, but as Andre, I think that I end up with these parents that have now had a kid with the shunt for so long and they obsess over every little change. I've had some kids that come in with Codman Hakim's where it's, okay, well, 110 is okay, but 100 is not, and 120 is too much, and they'll get their valve changed, and then they're back in my office 24 hours later going, I think my headache's maybe a little bit worse. Can we go back down, or can I try a one higher setting? And I just I have to laugh about it because we know that the error on the valve really means there's not that much of a difference between one setting on some types of valves. And I think that it gives them something to fixate on so that when you have kids who have other multifactorial headaches and a shunt, it becomes very difficult to redirect them into appropriate headache management.
Thanks. Thank you, Crystal. Dr. Uyakumar, do you have a comment, please?
Yeah, I use Strata very often. Since last 10 years, I've been using Strata for a long time, whenever it's possible. And for probably reason attributable to Strata, I have not seen a slit ventricle in my cohort. And I use Strata in most of the infants, but not in neonates. Neonates, I have the skin issue. So I don't use in neonates, but in most of the infants and older children, I prefer Strata whenever it's possible.
Thanks. Thank you very much. I look forward to, it will be nice to have, I'm sure there are some publications, but it's nice to see publications on these because my heart does sink when I see a child come with a slit ventricle or going to develop slit ventricle even after I thought I put a decent shunt. Thank you. So the next question is, what do you call which, so this is just a percentages, 56% of the people used fixed pressure, 29%, so 1 in 3 use programmable in this group, and in terms of flow regulating is small, and gravitational also small in this group. I'm sure it's due to course. So the next question was, if it is fixed pressure, which setting you use? I suppose as probably Professor Grottenhue mentioned, it's not just 3, you can go to 5, but I just try to keep it simple, but maybe I should not have. But on this low, medium, high, the answer was quite clear. There was no one in that 69, on the 38 people who had answered used a high pressure, but mostly people used the medium pressure valves. Dr. Suhas, you are in Israel, in your fellowship. Is there a tendency to use high pressure valves in Israel?
No. No,
it's
we don't use high
medium.
pressure.
Medium.
Low pressure.
Low pressure there, is it? Okay.
Yes.
So anyone here who uses low pressure valves?
I advocate using low pressure valves in patients with open fontanelle, so till about 14-15 months, and we have found that not being very problematic for us.
And is this because of the open fontanelle that you think that it will help with the drainage better? Is it?
Yes.
But you haven't seen with these cohorts. Then do you upgrade the shunt valve after, or do you just wait to see?
So that is where we thought we may have to upgrade, and we actually tell patients that we might the families that we may have to do that, but very rarely we have had to do that. I must say that, and that's why we have continued with this. That if we are putting a fixed pressure valve in a neonate, we would usually put a low pressure valve.
And in terms
we
of
have some differences between us, and not all the consultants do that, but a majority would.
And in terms of the slit ventricles, do you see an increased rate on them?
Surprisingly, the incidence of slit ventricle syndrome is not very commonplace in our country. I don't know if it is because of the strata valve, or if it is because like Crystal was describing just some time ago, that some of the symptoms are probably not so pronounced or not so talked about, but very few of us are either upgrading valves or doing any kind of decompressive procedures. In fact, during my training in England, I remember in 3 years, I must have done at least 5 or 6 procedures like that for slit ventricles. But here, I have not done even 5 in last 25 years.
Wow. Wow. Thank you. Dr. Suhas, do you have a comment there?
Yeah. I start with low pressure, and I follow the head circumference percentiles very closely. Whenever I see it dropping down, I change to strata. So there's an elective change of strata in many of my children.
Thanks. Thank you.
Naren, I have a different strategy.
Sure.
Fontanelle is open. I make extra holes in the medium pressure valve. So I don't have to use low pressure or medium pressure valves. I always use fixed pressure, medium pressure. If the fontanelle is open, I make a couple of holes extra so that it takes care of that and it doesn't cause over drainage. But at the same time, it ensures an adequate drainage so the child will do well. And I don't have the problems of using low pressure shunt and at the same time. Whereas if the fontanelle is closed, I don't do that. I'll just put the medium pressure and watch. So this has worked for me in avoiding at least some of the problems.
Sorry, Dr. Neelam, where do you make the hole? Sorry, where do you make?
Just above the slit valve.
Yeah.
Lower end, just above the slit valve, a couple of extra holes.
Okay.
So that will give a little more drainage.
Okay.
Then, when the fontanelle is open, it helps.
Okay. And so you just use the same medium pressure valve and then put more holes. Sorry, if I missed it.
Yes.
Okay. Thanks. Thank you. Professor Groton-Hughes?
Yes, I was wondering who of the people using low or medium pressure is actually measuring the opening pressure during the procedure. So with a to test, because we know that these valves are all acting differently. If you have 10 low pressure valves and 10 medium pressure valves, I don't know who is doing that. I'm doing it because some of these low pressure valves, they have an opening pressure of 2 centimeters, and some have an opening pressure of 10 centimeters. Then the medium pressure valves, some have an opening pressure of 4 centimeters, and some of them have an opening pressure of 15 centimeters. So it is amazing to see how different it actually is. And we think, we take for granted, but it is simply based on the mechanics of differential valves, especially the membrane types, that what we implant is probably there is not even a difference between the low and the medium. Many of them are actually doing the same. But I like what Dr. Neelam was saying, that we have to realize in neonate, unless the fontanelle is still open, that absolutely makes a big difference in how we shunt and how we drain CSF. The moment the skull really closes, it becomes a really closed compartment. And at that same time, the child is also, from being only supine, getting into more vertical positions. So this is typically the time that no matter you use low, more in the low actually, than in the medium pressure, the risk of developing smaller ventricles is larger. They don't all have a so-called slit ventricle syndrome. They just on the image have these very tiny little small ventricles. And that's the point. They can manage to do that, but the problem is that you have easily, and that's just based on the Monroe-Kelly doctrine, when it is closed, then if there is less CSF, there will be more venous pooling inside, and therefore a little bit of more, they typically come in with symptoms, let's say when it is a warm summer day and so on. So all this, the typical physiology is changed, and they manage doing that, so it's not necessary in all cases to make changes, but especially the fact that these two fixed valves don't differ so much is in favor of using a programmable valve, so that you have the possibility to adjust at least in the future the setting when the child grows. Unfortunately, the programmable valve don't offer anti-siphon. So they still can have overdrainage, no matter what kind of setting you do. And I had to laugh when Crystal was saying that about a parent saying, no, the child is not doing well with 100 and doing worse with 120 and 110. So all these things, it's so recognizable. That's the drawback also of programmable, because we think that every day and every hour and every minute of a day should be the same situation, which is simply not like we are sitting now. It's not the same situation. So actually in Naren, there is no difference. You have 38 people, 8 low pressure, 30 medium. My residents just say, I use medium because it is the best choice between low and high. I don't know what they do, so I choose medium. Medium is the middle way to go. That's for the neurosurgeon who I say, okay, I want to avoid slits. I want to be sure that it is shunting. Well, so I don't use low, I don't use high, I choose the medium. And they have no idea what they're actually doing.
Thank you very much, Prof. The two things is that just I do check every valve before I put them in. I used to actually use the manometer and measure what was the closing pressure.
That's
I have to say that I usually use 1.5, and I have been surprised by the range of closing pressures. You know, they are quite, and probably that explains the 2 patients I have with the slit ventricles as well. And the second question is that I didn't realize that the programmable valves did not have anti-siphon device.
Not all of them.
Not all of them, unfortunately. Well, the more expensive and the newer ones they do, but they are very simple differential valve, differential pressure valves, like it is kind of using a low, medium, high, and just change between the settings and nothing different. You still can have overdrainage, even with a so-called high pressure setting.
Daisy, do you have any comments on valve choice and your experience?
Ask Professor Neelam. He said he makes extra holes. What catheter does he use? Because Bactisil I find are quite flimsy, and to make extra holes.
Daisy, please come to the mic, closer to the mic.
Sorry. Just to say that I wanted to ask Professor Nilam, he makes extra holes. What catheter does he use? Because I find on Bacticil, if I make any extra holes, it's almost bricks.
No, it doesn't. If you can make you fold the catheter and slightly at the corner of that, if you make a small cut, it will make a semicircular hole. So
Right.
there the tube becomes little flexible, no doubt about it, but it really works.
Okay, thank you.
Thank you. I'll move to the next slide. Thank you. And which valve, this again, I'm just showing the percentages. Medium pressure was almost 80%, so 4 out of 5, low pressure 1 out of 5. And so the next question was that are you happy with the valve that you are using? Because I know as Prof. Grottenhuis mentioned earlier, if you ask many people why you are using a valve, they will say either that's how I got trained, or that's what my boss says, or that's what my manager says, or that's what the economy allows. And so actually 40% of the people that I surveyed of the 68 wanted, if they had a choice, to change their valve. So the 40, that's 59%. So that shows that what we do and what we want to do can sometimes be different. Maybe we don't know what will happen, but when we do what we want to do, but still. So of those people who wants to change, so those people who wanted to change, the people with the flow regulating valve, 5 out of 6, that's 83% wanted to change from using the flow regulated valve, whereas 64% of the fixed pressure people who use fixed pressure valve wanted to go away from fixed pressure valve, and 45% of those using programmable valve wanted to go away from programmable valve, and 25, 1 in 4 who used gravitational wanted to move away from it. Is there anyone here who had previously used programmable valve and now doesn't use programmable valve? If you do, please put on the chat side of things. So certainly those who use flow regulated valves are small, but the main thing I'm looking at is the fixed. The two interesting for me is the 64% of the people who use fixed pressure valve want to change, and whereas 45% of the programmable want to change. Let's go to the next slide. And which valve would you prefer? And so of those people who said that they want to change, the majority, the 19, almost 50% want to go to programmable valve, and 12 wanted to go to flow control valve, and 5 wanted to go to gravitational valve. Sometimes in these surveys, people, there are some errors as well, because when you go to the next node and say what you want to change, people still put the valve that they had actually been using. But the essence is that those people who want to change valve, they mainly want to go to programmable valve. And I will just take you to the next slide. I think it's the same. And so now then I looked at, if you are using, if you are using a particular valve, which valve that you wanted to change to. So if you are using fixed pressure valve and you wanted to change, then you are looking to go to either programmable valve or flow control valve. And whereas those people who are using programmable valve are keen to go to gravitational valve. And any comments on these numbers, Professor Grottenhuis?
Yeah, well, what you see is that this is the typical tendency of the belief that the next generation of technology is better than the one you used before. Mm-hmm. I think that I even presented that in a European Congress in 1986, that when, for the first time, let's say when programmables became available, everyone was enthusiastic about it. But they were so primitive at that time, actually they were withdrawn from the market. But we have this tendency to believe that the next available technology should be better than the previous ones. So if you have a fixed, you choose programmable. If you have, let's say, programmable, you think, okay, maybe programmable plus gravity. So add something additional to it. Have more facilities in it. You don't have here, because I know that, for example, in Germany, but also in my own country, the Netherlands, we see that there are now some shunts available with extra components, with chips in it, and for telemetric pressure measurement. Do you know that? These shunts, they are like a kind of train of 4 kinds of things that you have to implant in these poor patients. And this is the next step that you say, okay, now I have a programmable gravity valve, and I add another facility, which is telemetric sensor to it. So this must be much better than everything before, because now I have the possibility with this child, before I change the program, before I change the gravity part of it, I can measure telemetrically your settings over, let's say, 24 hours, and then think that I can do something more. But so this is, I think, what you see here is we still as neurosurgeons have this strong belief in improvement of technology, especially when it comes to shunts.
I think you make an important point that we always think the next one is better. Professor Dear Pujari, in terms of that idea, as well as in terms of financial side of things, what do you make of?
I entirely agree with what Andre had just said. I think there is, of course, a huge financial component, and Ben Warp's paper, with his Ugandan experience, when he specifically compared the Indian valve versus the pressure regulated valve, and showed that there wasn't really significant difference. I think that has also changed, because in India also there is a aspirational, I mean, you any parents you ask that there is a choice of shunts, and they'll say put the best one. And then if you really have to tell them that I really don't know what is the best one, but I can tell you probably pluses and minuses of some of these. While during that discussion, you realize that they are ready to pay anything for the valve. Even if it means that the child has to go from a special room to a general ward or something like that to reduce other expenses. And the point is for us to advise them that, yes, this is something worthwhile and they should probably do this, must do this. I don't think we have enough support yet. So I think people of my generation probably would look at all this with some circumspection, and I think it's very, very difficult for me to answer this question. I think in NPH, I'm a little better convinced that I'm using programmable valve, but I'm not sure about childhood hydrocephalus yet.
I agree with normal pressure hydrocephalus, absolutely. Yes, it avoids all the subdurals that we have seen before. No, I agree. And I had to laugh a little bit, Chandra, about what you say, that, of course, if you ask a parent, I mean, who in the whole world would not say, please give my child the best that there is? But your answer it is, we are simply not know what the best is. The thing is that if you have to drive from, let's say, Mumbai to New Delhi, and you have a Volkswagen Beetle, you will you will be there at one point of time. If you drive in a Rolls Royce, you also will be there, probably because of the traffic at the same time. Only thing is, the one is a little bit more comfortable than the other, but you reach your goal anyway. And that's the same as Ben Worf was proving, but also about this. We are not sure that this is an improvement, but let's not forget that the whole shunt technology that started 70 years ago really has changed the faith of hydrocephalus. It became a treatable disease because nobody of us remembers the time that this was a fatal disease. All children would die eventually from this, and all patients would die from that for decades, for ages. And it became a treatable disease. We can manage it now. And I think shunts are still there. I once gave a lecture and thought, what has changed in neurosurgery? Well, we still remove the disc with our forceps, still manually, and we still have shunts. We drill burr holes in the skulls. It has not changed. There are no robots doing this for us. And shunts are still there. And why are they there? They are still needed. So I think we need improvements, we need developments. The issue is that all the developments that we have seen are not really changing towards even trying to make it a kind of physiological solution, but it is manageable now. And so this is, I think the developments are still there. And during my lifetime, I probably will not see shunts going away within the treatment of hydrocephalus. But it makes this terrible disease, in many cases, terrible disease, still manageable for us as neurosurgeons. And allowing patients to have at least a lifespan nowadays.
Thank you very much.
Don't forget that.
Thanks, thank you. I think that's an important point, that it was a disease that
I think it's a very good point I had made. In fact, it's life-saving.
Yeah.
I think that's the point we need to remember.
It's not ETV. ETV also has changed a lot. It has given us a second possibility to treat certain types of it in another way. But shunts are there and they are absolutely needed. I often tell that to my patients.
I'm going to ask one question to Crystal and to Elias, and then just summarize two things.
Crystal has left.
Oh, Crystal, is Elias still there?
No, she sent a message to the chat that she had to go.
And the question is that in terms of, in Britain, we are not in a commercial system, but it's maybe a general one. If using a programmable shunt is also in a commercial medical care system, medical system, whether it is also that you want to show that you are using the latest and the newest system. But I think maybe that's a discussion for another day. But just to finish off with three observations. The first observation is that I'm sure you have all heard the study that was done where they blindfolded people and put someone in a Benz car and a Ford, and no one could actually know the difference between both of them. I think we all know that when something is shiny, we feel that it's better. It sometimes might be, but not necessarily. The other thing is, this is a discussion that we had on hydrocephalus shunts. I think it's a time to just reflect on Professor Chabra, who passed away last month, who had been an inspiring mentor to Dr. Agrawal, who developed the actual Chabra shunt valve. And it's really quite a moving story. If you haven't read, I think you should. I would really encourage everyone to read it. It's basically Professor Chabra, when he was a junior consultant, went to his boss and said, should we develop a cheap and effective shunt valve? And this is as told by Professor Chabra. Maybe I'm slightly adding, and his boss was quite supportive for it. And Professor Chabras had a resident who was very technically minded, both engineering and business minded. So he went and said to him, can you develop this, this valve that is cheap and effective? So his resident goes on, takes another 7 years to develop this valve that works and patents it. And so it was 78 that he asked his resident. It gets patented in 1985. And it's amazing that all the work was, according to Professor Chabra, was done by Dr. Agrawal. But he actually, Dr. Agrawal, to honor his teacher, named the valve after his mentor, which is quite noble. The other thing is that Professor Chabra declined to take any shares to keep the price low as well. So any, Professor Dear Pujari, your reflections?
No, I think I must add to this that he was really not only a person with some innovative ideas, but he was a very humble human being. He was the first chief of a new department, a new university department which was built, and he really developed it well. If you look at the whole, his proteges and all the people who have come out of this and have made a name for themselves, they would all tell you that he always behaved like one of the team and it never behaved like a chief. And I thought that was a very big thing at that time. He belongs to the second generation of neurosurgeons in India. And during those times, I think these qualities were extremely rare. And I have personally had some good moments with him, which again shows that he was a very humble man, apart from being a good surgeon and a good administrator, the way he conducted his department.
Thank you very much. So I comes to the point where I thank Mr. Rodriguez. It was a project that we did together, and thanks for Desi. And Desi, do you want any?
First of all, Naren, thank you very much. Thank you to everyone, especially Professor Andre, Professor Deo Pujari, Professor Nilam, and Suhas, my good friend, for their participation. Everything you all have said had added to my knowledge personally, and interacting with all these people and the forum has helped. I can see the chat going haywire now, and I really appreciate. Thank you very much, Naren, for conducting this seminar and webinar, and please continue the good work. And thank you everyone, and all please stay safe.
Thank you very much to everyone who participated and everyone who contributed.
Thanks, Naren. Thanks, Desi.
Thanks for organizing this.
Always a pleasure to see you, Andre.
Always, always.
We'll meet again for part 2 in a couple of months. Thank you very much.
Thank you.
Good to see you, Linkat.
Thank you.
Yeah.
Because bye-bye.
Bye-bye, Naren. Bye-bye, Desi.
Thank you.
Nice to see you again.
Bye-bye, Nikos. See you.
Have a lovely weekend and
stay safe all.
And we meet again soon.
Please stay safe.
Thanks. Thank you.
Sure.
I'll leave the computer for another 15 minutes, so anyone who wants to chat and get to know, you can do so. Take care. God bless you all. Thank you.
Well, Desi, it was really a pleasure seeing you, though we met briefly during the INRC. I think it was a bit too crowded.
Yes.
But I think that was also a good venture. Naren is really
driving force.
Yes, and he's keeping everybody busy, and I think it's worthwhile. These kind of dialogues really help clear your mind a little bit in all these confusing times.
Correct. Thank you. And I hope to meet you all again. Hope you can visit here, or I can come that side sometime when I'm visiting my mother.
I'm sure whenever you are coming to India next, you should spend some time in Mumbai. We'll be very happy. But it doesn't seem to be any time soon, unfortunately.
No. In fact, I just wanted to say there was a chap you must be knowing who is now in Gosh doing a fellowship. Who has applied? Yeah, he's applied here and he's been offered a post starting in December if he can make it.
Saurav is a nice chap. He worked with us a couple of years, and he's good. I don't know how long he wishes to stay, but if he does, good luck to him, and I'm sure you will be happy with him.
Yeah, yeah. No, he called me and told me that he had worked with you, so I said I have to mention it to you. Yeah.
Daisy, greetings to Guris. Don't forget it, okay?
No, Nikos, I'll definitely tell him.
It is, you know, it is, we are very attached with Guris from many years, okay? I hope after coronavirus to come and visit you in Birmingham, okay?
Definitely. Thank you. Yeah, definitely. I'll tell Girish.
Yeah. Stay safe, okay, Desiderio?
Stay safe, Nikos.
I'll leave you to chat with us, but I think Atul's daughter is joining you, or has she joined you already?
Not yet. No, everything has been sort of stalled at the moment. She's joining. Girish told me that she was coming.
Okay, stay safe, and we will see you each other.
Hi, Desi. That was very
Well done, well done. That was a success.
It was really nice.
We made over about 4 o'clock actually.
Yeah.
I just looked at it, I was fast. No, that was good, but you know, that's everybody was active. And it was great. Like Professor Sandeep Pujari said, you know, at the end, yes, every time he also learns, we also learn, everybody learns, you know.
It was really nice. To be honest, I didn't invite any.
I couldn't get Professor Gratinus. I had to say Professor Andre every time. It's so Gratinus.
And I call him Gratinus, but I think his name is slightly different. You pronounce it.
First I said Gracious, so I couldn't.
Still on the podium. And we are still on YouTube.
Others don't have. I wonder, yeah, I've had 2 cases where back pressure was there. But it should be such a extended stitch. Especially with the slit one, you know, in the condiments, there is this new practicing bed. The practicing is the one that does not sit well. So that's what I was saying. When Professor Dillon said, I didn't understand that he doesn't have a slit one. They're just taking one hole or multiple. What I used to, why I was not taking the right. Use the fine scissors. I used to use the bone cutter. Bone cutter makes it a process to like how to make scissors. You know, see, even in the data, whether this one, we use 1.5. 1.5 is for the pressure range. Yes, it's a huge pressure range. You can go from anywhere from low to. And that's enough for a giant. Yes, that's the thing is, I thought of upgrading the one, but why upgrade when you don't need to? So what I do, I accept that the medium pressure the one that I do to keep the pressure of our skin. I think that I would want to that's what I do. So, but I don't do blow pressure. If I was going to the program, I would do. This is open. And this crease is much better than here. It came from the kilo. Puckered. Then I was like, hello, I used to go and see it. But I continued. Muscle, and now east, cranberry, do it. I know that you want to. I like to do it. I said, I don't have one to do because for me, I got what I just how the system not the two goals, not the and not yeah. Again,
Oh, I thought you were basically here and you have to go home. There's something? I see. Oh, you are from home presenting, huh? Okay, okay. I'll wait for you till you come, then I'll go. Then if you have told me I would have done you around there. Okay, come, we'll go.